All right, now that I told you about all the stuff you don't care about, let's look at anatomy. Today we're going to cover vision. I don't know if we'll get the image. Those are two different things. Vision is associated with the eye structures and looking at how the extrinsic muscles move the eye. There's going to be some differences for y'all that have studied this before, and I'll show you what I mean. And then image is how things are processed at the retina, like how photons strike and all that. So they're separated. The first part of vision, we'll go over like eyes. Whoops. Throws me off, these monitors aren't working. Structures or accessory structures of the eye. Most of these we're familiar with, and they didn't give all of them funny names that we're not used to. Eyelids, eyelashes, eyebrows, the lacrimal apparatus. We're going to look at how we form tears. And then our extrinsic eye muscles. And we got introduced a little bit to extrinsic eye muscles in cranial nerves. And now I'm going to come back and tell you basically those other four. So if you look at just the eyelids, and I do have to define this out. So you have upper and lower eyelid. I know I don't need to do that, but okay. Upper and lower eyelids. And we don't often think about it, but they are there to protect our eyes from foreign objects, to move lacrimal fluid across the eye to keep your eyes moist. That's why you need to blink. That's why it always amazes me when you talk to people, or like a lot of news reporters, when you look at them, they're talking the whole time, they never blink. See those people? I don't know how their eyes don't dry out. Because they're going to spread those secretions across your eye. When you look at the whoa. The upper eyelid is more movable. Right? We all look at each other and we close our eyes. The upper eyelid comes down a little further over the eye. And the muscle that raises that eye is that levator palpebrae superioris, which when we looked at the muscles of facial expression, we excluded this one because that's the muscle that holds that upper eyelid up, and you can be in your full non-expression absence seizure, and your eyes will still be open. We always think about it. You have no facial expression. Your eyes are open. Probably like me today. When you look at spaces, the upper and lower eyelid are called palpebrae, and when you look at the space between them, from here to here, all of this, like everything you can see that's not skin of my eye, when you're looking in, we're talking about the space between the eyelids. It's called the palpable fissure. Right? Some people who've never studied the eye get a little confused because if you're looking at the eye and you're just doing like point and see anatomy, you say, what's this? And you're pointing at the white of your eye. Well, that could be multiple things. You'd have to define that more because are we talking, are you trying to ask me what the sclera is? You're trying to ask me if that's bulbar conjunctiva? You're trying to ask me if that's palpable fissure. And you have to define that out. I'm getting ahead, and you'll see what I mean as we go through the other one. Where the palpable fissures meet at each side of your eye, there's an angle. Okay? And so the medial side, when we get over here, this is called the medial commissure. And over here, I got to draw outside of it so you can see it, but that's the lateral commissure. Now we know, and I know everybody, I'm always sarcastic, right? I know everybody looking up here is like, well, obviously that's a right eye. In ophthalmology class, a lot of times they're giving you these pictures, and you don't see the whole face because they're focusing on the eye. But the one thing that you're going to look for is the lacrimal caruncle. So right where I made this, the mark looked good on my screen. What happened to it? This angle, if you notice on your screen right here, there's a little raised area. That's called the lacrimal caruncle. It's always in the medial commissure. So if you find that, we know by looking at this, then it's a right eye. And you can kind of make out that that's their nose to the right there. But that way you can orientate the eye. Always look for that lacrimal caruncle. And that's just sweat glands and oil glands that are in that area that are going to be released. Now if we go through the layers, like we're going anterior to posterior, going straight back through the eye, the first thing we're going to see is we do have an epidermis, a dermis, a subcutaneous layer. But then we have a layer of muscle. I gotta let somebody know that this computer won't kick on this podium. It makes it so much harder to draw. Or I could just get up to speed with life and get like one of those pens from my government computer. You know that would go well. This muscle is orbicularis oculi. And while it doesn't look like it here, it's a circle around the eye. So that would be the next layer that you see there. Then behind that, we're going to have what's called the tarsal plate. The green structures in your upper and lower eyelid, and if you've ever flipped an eyelid or flipped your own, you notice you have that hard-looking kind of cartilaginous-looking plate. That's your tarsal plate. And in that plate, you have tarsal glands, or what's actually called Mobibian glands. And we'll get to those on the next slide. And then just behind that starts what we call our conjunctiva. So once we make it back here to the back of this eyelid. So the tarsal plate is just connective tissue, and it gives structure to that eyelid. But what's more important in them is they have Mobibian glands in each of these plates. So if you look really closely and kind of enlarge that green area, you'll see it really has a bunch of little darker green dots, and those are the glands that are in there, and they secrete a fluid that helps to keep your eyes from sticking together. Right? So our kids that have problems with these areas, right, their eyes get all gunky and start sticking together. But that's what it's for. So whenever you see a Mobibian or a tarsal plate, Mobibian gland, once again, it's another thing you have to be asking about it, because any books that point at the tarsal plate and they're asking you about the gland, well, the gland's in that plate, so it's almost like labeling the same thing because it's so small. And then we have conjunctiva. So conjunctiva is really just a type of mucous membrane. It's very thin. And if we look at the back side, I'm going to try to draw very slowly here. If you go to the back side of the eyelid, and then it turns and comes back along the eyeball. Same thing down here. And I stop because when you look at, let me know if this doesn't make sense. At the back side of the actual skin of my eyelids, the last layer is called the palpebral conjunctiva, behind the eyelid itself. And it goes up and back in and comes around the white of my eyes. But my pupil and my iris, the colored portion of your eye, the conjunctiva doesn't cover that. So the conjunctiva that's covering the actual whites of my eyes that you can see is called the bulbar conjunctiva. And what's lining the inside of my eyelids is the palpebral conjunctiva. And they're one continuous structure that connects. That's why, you have people that lose their contact in their eye and they think it's gone up into their brain. It's gone. I don't know where it's at. Well, it's up there. It's up there where that fold of conjunctiva loops back. You can't really push something back behind your eye because it would hit that. Does that make sense? I hope so. Right? Contacts often get stuck up in here. I don't know how they can't tell they're there, but anyway. But we're not going to cover, the bulbar conjunctiva is not going to cover the actual cornea. Because overlying your iris and your pupil is a clear, transparent covering called your cornea. And that's part of our visual axis. Light is going to be refracted by hitting that. And if the conjunctiva was over it, and there are conditions where people grow conjunctiva that goes over it, it's going to greatly distort your vision. So there's no conjunctiva over that area.
Sir?
Yes?
So in the picture, it looks like it goes over the cornea. Does it just dissipate, or when does it actually terminate? If it's going on the path?
That's just because how I'm drawing it. So it would actually stop. I'm going to draw a straight line. Here, and I drew it too long, but here. So almost think of it like attaching to. Now remember, a lot of these eye pictures are hard to visualize because we're not realizing it's a globe. I see it. I broke it last semester too. So now when we talk about the why of the eye, most people go, oh yeah, that's the sclera, which is true. We're going to talk about that later. But overlying this sclera, white portion, is a very thin mucus type tissue, and that's your conjunctiva, the bulbar, and it comes up to the edge of the cornea, but it doesn't go over it. How it's attached, I mean, yeah, dissipate, I guess is a good word. It kind of ties in. I can't believe you broke that. We'll leave that there in case I need it. All right. So that's how it looks. In the upper lateral portion of your eye, you're going to have the lacrimal apparatus. This is where we get our tears from. Right? But tears are actually called lacrimal fluid. Right? Lacrimal fluid is very important for our eyes because it has salts in it, mucus, and then it has some bactericidal type enzymes. So our tears serve a really big purpose, not only to keep our eyes moist, but to keep bacteria and things out of our eyes. And the way it's going to work is in each lateral side up above your eye, you're going to have a lacrimal apparatus. And this is one of those things that comes up often as questions like, what is the flow of lacrimal fluid? You're going to hear that in ophthalmology because they talk about how you spread this across your eye. So I would learn these in order. Lacrimal glands secrete lacrimal fluid. That lacrimal fluid is then going to drain into a lacrimal duct. So there's several of them, and these ducts open just at the underneath of that eyelid. And then the tears are going to start to pass medially across the eyeball. But actually what you're going to do is blink. And when you blink, you're going to see that it's going to do like a Z pattern. You're going to spread that fluid across the eye. But we have to have a way to drain this off because we're making it. So the next area that's going to enter is it's going to go into what's called the lacrimal punctum. Most people who have kids, or even themselves, adults don't have as many problems with it. But in the upper and lower eyelids, right in the medial side, if you look in a mirror and you actually pull your eyelid down, you can see there's kind of a little notched area on your eyelid, and there's a very, very small opening. That's a lacrimal punctum. Sometimes they look a little white, like when you look at them. And if you have kids, you know about this because they often get plugged. If those lacrimal puncta get plugged, like with mucus or dirt, potatoes, whatever they're into, they'll wake up and their eye will be red. But if you take like a moist compress and kind of massage that back and forth, it'll open up that puncta, then the tears, the lacrimal fluid can drain. Because the lacrimal fluid's not draining, their eye's going to get all gunky and red. And I'm telling you this because when my kids wake up, that's the first thing I'm doing. Because you're going to school. This is not pink eye. That's a long time ago for me. It's not pink eye. You're not staying home. We don't stay home. But that's where your lacrimal fluid goes into. After it goes into the lacrimal puncta, which is up and below, you're going to pass into the lacrimal canals. So this is the superior lacrimal canal and then the inferior lacrimal canal. Those lead to the bigger area called the lacrimal sac. So the large structure that we see here is they're draining into the lacrimal sac. And then ultimately that's going to go to the nasolacrimal duct, which explains why when a child or an adult, anybody's tearing up, your tears have to go across the eye like that and drain through the lacrimal puncta to the lacrimal sac, to the nasolacrimal duct, and into your nasal cavity. But if you have a cold and you're stopped up, or you produce your tears too fast, they're going to spill out over the eyes. But if you notice any kid that is crying, what are they also doing? They're snot like crazy coming out because they're draining all those away. So that's how it, so learn the progression. Lacrimal glands to the nasolacrimal duct. So we normally carry, I just said this a second ago, they normally get carried away or evaporated just as fast as we make them, so that's normally not a problem. Wash things out of your eyes. Another way you could have like somebody wearing what do they call it? Unrelenting citric pine and irritate your eyes. Or cause them to secrete. I hesitated before I moved to this slide. We may have to break out the whiteboards for this. And since I was up most of the night, I might make sure we get through this. My goal here with the extrinsic eye muscles is take as much time as we need to understand what I'm saying. Because if you go study this on your own, it doesn't always make as much sense. It does, you're going to need to and kind of think about this, but I can help you make sense out of it. Because there are 6 muscles that move the eye. Since they're not inside the eye, they're called extrinsic muscles. So we have superior and inferior rectus, superior and inferior oblique, and then we have medial and lateral rectus. If we go back, we could say, well, we know that these are innervated by cranial nerves 3, 4, and 6. I didn't give you this formula before, because we didn't really need it, but that is a formula that tells you what muscles, which extrinsic eye muscles of the eye are innervated by which cranial nerve, because we're going to be testing them. So it's LR6, SO4, subset, or you could superscript it if you want, whatever, 3. So that means that the lateral rectus muscle is innervated by cranial nerve 6, superior oblique is cranial nerve 4, and then the 3 stands for the fact that the other 4 cranial nerves are all innervated by cranial nerve 3. Okay. So as we go through these, which we didn't do during cranial nerves, we're going to do now. That's a good formula to remember. So as we start out looking at the eye, I may actually keep this up here. The extrinsic eye muscles are attaching right outside of the eye. And they're coming from the back of the orbit. And so they're going to have the ability to pull and move the eye in different directions. Take that off, it's going to fall. And so when we look at that, they move the eye laterally, medially, superior, inferiorly. If you were to just break them down and say, well, what does each individual muscle do? You'd say, like, lateral rectus, right, abducts the eye, it moves the eye out. You got both eyes, right? They're going to abduct different ways. And adducting would be medial rectus job. They're 2 of the easier muscles to understand. The obliques do, when you study ophthalmology, you're going to see they preserve rotational stability. Every time I think about that, I go, okay, well, we have muscles. This is our starting point for understanding this. When you look at the eye, if we wanted to put like a plus sign over it, and we wanted to say, okay, we have a muscle called superior rectus and inferior rectus. Okay? And so you'd have superior rectus, inferior rectus. Then we have, I'm looking at my right eye, we have medial rectus and lateral rectus. And that sounds simplistic. It's not, because for one thing, the eye is, there's 2 things I need to say here, I think. It's the eye, that plus sign would not be exactly straight onto the eye. It's a little off-center. And we have obliques that help preserve it from rotating, because, we can move our eyes all sorts of directions. And then the second point in understanding all this is, when you move your eye around, just walking around the room looking, you always use more than one of those muscles. And you always use a combination of 2 or 3 muscles to achieve different ways to look around your eyes, right? But we're going to break it down, because ultimately when you do physical exam, we want to test individual muscles. Well, really the cranial nerve that innervates it, but we're going to test that individual muscle. So we need to learn anatomy, and then we need to learn how we do our eye exam. And I'm going to go back and forth a lot. This is my eye exam. This over here I always say is Mr. Wright's anatomy. You know, why does he tell us that kind of stuff, anatomy? Because over here, a lot of you already know. Not all of you. I realize that not everybody was medical before they got here. But under the eye exam, we learned Bates, and I did too early on. And Bates shows us what muscles are responsible, why we're doing the eye exam, why we do it. But I did learn when I was in ophthalmology, they do surgery on these muscles. And so we're going to learn real quick, we're going to learn in a simplistic kind of way, what is each muscle's individual function, and then we'll learn how to test them and isolate some of them so we can do that. And that's your eye exam. So here we go. Extrinsic eye muscle movements. If you think of like a compass, that's what we kind of use here. Now this would be a right eye. See the lacrimal caruncle there? And so in this right eye, we have possible motions. And we're going to start to give them a different way to look at them. If I'm looking at my right eye and it's going this way, we would call that up and in. If it's going out, we call that up and out, down and out, down and in. So that's how that's set up. Of course, in and out, up and down. Those are all motions, and they're called cardinal directions of eye movement. Cardinal directions of eye movement is an anatomy, a study of anatomy. But 6 of these we'll see are considered cardinal directions of eye gaze. Right? So if you look at the bottom, I put these are the cardinal directions of eye gaze, and they're associated with one single muscle. So I'm going to switch, and it circles them. Those are the cardinal directions of eye gaze. Now, as I go through, I'm going to keep recapping. First thing is, I don't need you to do a list of like, these are the muscles of cardinal directions of eye movement. These are the muscles of cardinal direction of eye gaze. I don't need you to list them out that way. I need you to understand that the cardinal motions or movements are one subset of looking at it, and gaze is actually our physical exam. Because when you talk about anatomy, I'm hoping I'm making sense. If the eye is looking straight ahead, and I said, okay, what muscle is responsible for moving it into the up and out quadrant? We don't know which side, we'll call it a right eye. So which muscle is responsible for moving it into the up and out quadrant from the position of looking straight ahead? That would be an anatomy, study of anatomy, of which muscle is really responsible for doing that. Keeping in mind, we know that when we use our eye, we normally use more than one muscle to do that. But in anatomy, we look at what muscle actually does it for anatomy. When you get over here to cardinal directions of eye gaze, we're going to say, well, instead of starting from the position of looking straight ahead, what if we started from the position of abduction? Or we started from the position of adduction? In that case, there's going to be some differences, and that's the part I'm going to try to explain to you. And I'm going to show you why that's important. So then I went back and I use this picture a lot. I went back and I added all the cranial nerves that are responsible for those muscles. Cranial nerve that innervates a muscle is never going to change, no matter what I teach you today. That's always going to stay the same. So LR6, lateral rectus 6, right, superior obliques 4, and then inferior oblique, superior rectus, medial rectus, inferior, all of those other 4 are cranial nerve 3. We're building to something. So if you're looking at the eye starting position as looking straight ahead, and getting to one of the cardinal directions of eye gaze, to look around basically, it's not as easy as just saying one muscle moved it. Like I said, it means that more than one does. So I'm going to try and do some Albert Einstein and explain it simply. I'm not going to sound that way though. Every time we talk about anatomy, right, we're saying, well, here's the eye, and we're starting from a position of looking straight ahead. In anatomy, if I say, well, what muscle is responsible? If I'm looking at this is right eye, and I say, well, what muscle from the position of my eye is looking straight, like I'm looking at a Snellen chart, my eye is looking straight ahead, and I said, well, what muscle would be responsible for moving it to the up and out quadrant? Right? We would say inferior oblique, right? And that would be cranial nerve 3. So that's going to change because if I'm looking in anatomy and I say that, and I say that muscle does it, but I just told you that in order to achieve that direction, what do we normally use? More than one muscle. So if I want to test my cranial nerve 3, I want to test the inferior oblique, I was working with that, inferior oblique, what am I going to have to do? I'm going to have to find a way to isolate muscles of the eye. Have you ever worked with physical therapy, rehab, just doing muscle testing, like testing for supraspinatus, which they're deciding that's not a great test anymore. But if you test for rotator cuff tears, you ever seen empty can? Right? Cracks me up with empty can. You see big old burly people, and they're out there just cranking down people's arms. I'm like, if they have a rotator cuff tear, I can just take their arm down there. But why do we do empty can? I just said the word. Isolate. Y'all know that more than classes 8 years ago even, because more people are looking at exercise physiology stuff, and they understand even more that in order to build up certain muscles, you need to do things differently, like switch the way you do your curls. You do them this way, you do them this way. That isolates two different muscles. Same thing happens in the eye. This is nothing new. But we need to isolate them so we can make sure we're only testing what we need to test. That's called combined action. We need to, in order to test eye muscles, we need to eliminate combined action. So when you look at the eye, if it is fully abducted away from the nose, only superior and inferior rectus muscles can elevate and depress the eye. So when we look at this, superior and inferior rectus, respectively, superior rectus elevates, inferior rectus will depress the eye. But if the eye is fully adducted towards the nose, only superior and inferior oblique muscles can elevate and depress the eye. Now what's interesting is if we go back and look at the muscle, I didn't say this before, the muscle responsible for moving the eye into the up and out quadrant is inferior oblique. Doesn't that sound kind of weird because it's the inferior one? Because if you look at inferior rectus, it's bringing it down. But the obliques are kind of flipped, so superior oblique brings it down and out. If you didn't see, I'm seeing a bunch of puzzle faces. Y'all didn't notice that earlier, I don't think. So the obliques, based on their name, do an action different than what you think. And that's because, and we're not going to spend a whole lot of time on it, but I'll show you one, is when you look at the obliques, I kind of reference this in cranial nerves. Superior oblique, right, that's going to attach to the eyeball here, it actually goes up towards the front of the orbit and goes through the trochlea. Remember SO4, trochlea? It goes through that trochlea and it loops and comes back and touches the eye. So when it contracts, it pulls it down. And inferior oblique kind of does the same thing. We'd have to study all the origin and insertions of the eye to understand that. Or we can just, for now, learn the charts of what I'm showing you. All right. So we start to, anytime you see, whether it's in ophthalmology and here, if there is this H pattern over the eye, that implies that you're doing a physical exam, and so you're only concerning yourself with the muscles of eye gaze, how we use them. So anytime you see the H, that assumes that. There are two ways that, and if you're still not getting all this, you go along. I'm going to do some recapping once we tie it. We'll come back and do some examples. If you look at the eye, and I say, well, I can put an H over it, and the H is the exam. Right? If you didn't know, there's a certain way we do the exam. I'm going to show you in a minute. But it's an H pattern. And so when that H is there, that means that this is the cardinal directions of eye gaze during an eye exam. Another way that they can do this is show you a picture of an eye. If an eye is looking straight ahead, that's anatomy. But they can start out and say, okay, well, if the eye is abducted, what muscle can move it up and down? That's what I'm going to get to. There's a difference. Is the eye always look? Is the eye looking straight ahead? Are you abducted or adducted first? That's how we're going to eliminate combined action. Okay, so let's read these a little slowly. This is where we'll start to see if we're getting. If you remember, looking for the position of straight ahead, the inferior oblique is responsible for moving the eye up and out. So you would say, well, if the inferior oblique was responsible for moving the eye up and out, and that's cranial nerve 3, you would say the eye is in the up and out quadrant due to the action of cranial nerve 3. There we go. You're ready for this? But when we abduct the eye first, I underline these things, when we abduct the eye first, the muscle that's going to be responsible for moving it up and out is now superior rectus. And that is cranial nerve 3. Remember, the cranial nerves always move with the muscle, so the cranial nerve in that situation didn't change. And so you're like, great, I got it. That's no big deal. It is until we go to the next slide. So now if we start for the position of the eye looking straight ahead, and we say superior oblique is responsible for moving the eye down and in, if that's the case, then you can read the screen. What cranial nerve is responsible then from the position of looking straight ahead of moving the eye down and in? Cranial nerve 4, because superior oblique is innervated by cranial nerve 4. All right? This is here comes the issue. During a patient exam, when the eye is fully adducted first, right, and we move the eye down and in, it's no longer superior oblique that does that. The muscle that does that is inferior rectus. But inferior rectus is cranial nerve 3. So in this case, the eye had achieved the down and out quadrant, and depending on whether you're doing an eye exam or anatomy, cranial nerve can change to accomplish that. That's the confusing part, but I'm going to keep showing you and recap this until we get it. So I'm trying to get through it, and then I'm going to give you examples. We'll figure it out. Like I said, nothing will ever change this formula. The only thing that's going to change is deciding an anatomy or an exam, what muscle allows you to achieve that position of the eye. The muscle changes, but the cranial nerve that's associated with that muscle never does. All right, so having said all that, and just to be a little funny, now that you've got all of that, you should fully understand this with no problem. So when I look at this, it's biased because not only have I built it and used it, taught it, but I look up there and go, well, that's pretty obvious. But it's not. Not at all. It is once you get it. Once you figure this out, this picture makes perfect sense. All right. So in red, what I've done here, in red, you see the muscles labeled and their cranial nerves that are responsible for moving the eye in the indicated direction from the position of looking straight ahead. Anatomy. So red is Mr. Wright's anatomy. If I just taught that, forget, maybe I'm anatomy and I don't even teach physical exam. I would come in here and teach you, hey, the muscle that moves in these different directions is these in red. So in that case, if you start to pair these up, this is where I'm going to help you. If you look at the individual eye, the red, and this is a right eye, your obliques, I got to try to close one. In anatomy, your obliques, right? Inferior oblique, superior oblique, superior rectus, inferior rectus. So the rectus muscles are in the middle, right? That's anatomy. And that's why we have to say, well, we're looking for the position straight ahead. But the ones in blue are the anatomy of eye gaze, and so that implies that we're going to do, or this is what happens when we do an eye exam. So in order to have the blue areas make sense, that means that we have to use the H. I combined it all into one chart, and I came over here because this is the exam side. So in the exam, we're going to move the eye. When you do an exam of the eye, if you've ever done them, you're not supposed to be like me when I was a medic in the 25th Infantry Division, 1993. People telling me, hey, go do the eye exam. You know, and I'm, yeah, follow that. Follow it. I didn't know what I was doing. I admit it. Nobody ever sat me down back then and said, listen, there's a purpose here. When I'm staring at that finger, I'm looking straight ahead. I'm going to do an eye exam. It is a purposeful movement. You must start the eye exam. You can't just go, hey, follow my eye. It's not like that. You have to make the H pattern. Doesn't matter which way you go first, but to start it, we're either going to abduct or adduct the eye first. So the way you do it is you say, stare at my finger, and I adduct, up, down, back up, cross, up, down. You can do it either way first you want. The key thing is, what's the first motion? Adduction or abduction. And the purpose of that is to eliminate combined action. This is where I need you to hold on to a leap of faith with me. Doing that, because you don't want to get too deep into this, doing that is a form of isolation. Because what they've seen, this is the black box method, what they've learned is if you abduct or adduct the eye, it will isolate the muscles and only allow a certain muscle to do that motion. But when that happens, this is where I lose a lot of people. A lot of times over here, I'm going to come back. I'm trying many ways to get this across. We'll see here very soon if we do. Okay, I should have wrote them on here. I'll just save it. I need something different. Let's do this. What's this thing? Oh my goodness, that feels like the mud I was making. All right. White, this is a terrible, terrible thing. White is my rectus muscle, superior and inferior rectus, for my right eye. This pink blob, whatever it is looks like a little mouse, is my obliques. So in anatomy over here, my rectus muscles are here, my obliques are in the middle. Now it's associated with both eyes, so you could reverse that and say, well, I have rectus muscles outside, obliques inside. Lateral and medial rectus never change. Yeah, don't worry about those. So my obliques in pink are here, my rectus muscles are here. Okay, but I like to use my right eye, so my obliques are here, rectus muscles are here. If I'm looking straight ahead and I go towards an action, that's what I'm going to be visualizing. When I do the exam, I'm going to pause after this. When I do the exam and I abduct or adduct you first, what happens to this one eye is this. Another way I like to do it is this way. They switch. Your rectus muscles that are out here go to the other side, they don't go to the other side of the eye, they go to the other side's motions. Okay, so you're switching your obliques, and you're going to abduct them first, and in that case, they're going up here. That's easy to me to say that makes sense, but until we start doing some questions on these, it may not. For now, in blue, if you noticed, in blue is our gaze or our exam. Medial and lateral rectus, did they ever change? No. Let's look at just this one. The eye, from the position looking straight ahead, if you achieved the down and in quadrant, that was inferior rectus cranial nerve 3. If you do a patient exam and we adduct them first, now the muscle that's going to move us down into the down and in quadrant is superior oblique 4. It's just a fact. We did it by isolating. We abducted or adducted first. Now you can keep trying to understand this, or you can just trust me and learn that that's a fact. Right? Because some of you are really deep into wanting to understand this, and I'm trying to help you. And I'm going to give you examples and ask you a few questions. But at the end of the day, we really are concerned more about the nerves. When do we do the eye exam normally? During a cranial nerves exam. Right? So we do an eye exam to try and figure out. When I say eye exam, that's going to include like vision. But during our initial cranial nerves, right, we're gonna do an eye exam. That's why we're doing it. So we really care about the cranial nerves. But if you don't learn this, then we don't understand what changes. Now let's look at this for a second. Stare at it intently. This still has all the same components as this, except the muscle names. This makes it a little easier to see. This is, if you're kind of getting it, don't listen to what I'm about to say. I'm going to tell this to those people who go, take your word for it. I'll take your word for it. Look at the top. Like I said, I'm serious. Shut down your ears if you don't like simplistic explanations. Up here, the up and in and up and out quadrants. These muscles may change, but the cranial nerves always stay what? Same. They don't change. It's always cranial nerve 3. It doesn't matter what's going on. So look at the bottom. You have cranial nerve 4 and 3, cranial nerve 4 and 3. So only the bottom changes, and that's why I do this. We'll just do that. If this is my rectus muscles, my short finger, and here's my obliques, right? Once that abductor adduct, they just switch on the bottom. That's an easy way to think of it, to me. Maybe not to you. Some of you are like, no, it's not. So during an eye exam with this age, right, these are the cardinal directions of eye gaze. So now I've just listed all the cranial nerves in their direction of movement that you would use. Right, so let's start to see if we kind of are getting this. So if you look at cranial nerve 3, which innervates the inferior rectus muscle from the point of looking straight ahead, but when you have the eye fully abducted first, now that's going to be superior oblique that moves the eye down and in. If you go to the next, you say, well, although cranial nerve 4, superior oblique, causes the movement from the position looking straight ahead to depress the eye, but when the eye is fully abducted, the only muscle that can do that is inferior rectus, which is now cranial nerve 3. The last thing, and then this is a funny thing to say, but once you get out of this class and ophthalmology, none of this crap. I mean, it's true. Because anybody who's in here, our 18 deltas, we don't have Navy Corpsmen in this class, anybody who's studied ophthalmology tags, they all know that nobody cares a damn about Mr. Wright's anatomy. Not at all. Ophthalmologists do, but clinicians don't. Because we don't use anatomy books to do physical exams, really. We use physical exam books like Bates, which you're going to use. And Bates' physical exam says Mr. Wright's an idiot. Because where are they? This is their picture out of Bates. Where are the obliques? Normally the obliques are out here, right, in anatomy, but they don't even address it. But it doesn't really matter clinically, as long as you know why you're doing the eye exam or how to do it. Because they teach you to do the eye exam, and then they tell you if you can't achieve, if you adduct the eye and you cannot get to the down and in quadrant of that eye, that means there's a problem with superior oblique. And because we've isolated the muscles already, so Bates is assuming that you already know that eye motions take more than one muscle. But during the exam, somebody studied it and said, well, we can isolate it. So now we know that the only muscle that's going to do that during the eye exam, if you do it right, is superior oblique. That kind of making sense or no? Okay. Let's throw out a question. So from the, what's the break? Tell you what, think about it over the break, and then I'll just throw out some questions off the top of my head with this, and we'll see how we're doing.
I need to take a walk.
Difference of ease of action. If you think of them as bigger muscles, you know, like if I have my eye down this way, you know, down and out, it's just that opposite side, down and out, is all of that trochlear muscle. But if I move it all the way out here, maybe it's lax right here, and the muscle brings it down. I don't know. But again, maybe like because tension, because think about it. You can think about like this muscle, you know, like maybe get down here and doesn't have to down. I can learn it as don't you know these ones it's June, not July, so why are you Julying?
I don't think it's like for herb therapy like here. I don't get it. Oh, you're crazy.
This last one, I was like, okay, this is actually no, well, she's parents, I've been her mail, test on me, and that's been a lot better.
I like the red and
Oh, you do? Yeah, you can do it.
I understand this one, just not just the rest of it. This makes sense to me, the rest of it. I don't want to. The paper and everything, I don't understand what it is.
What does that mean? Explain. It's simple. You know what? I'm gonna be honest with you, Adam. I'm like, okay, that's what I thought. Just say that. Say less time.
So you would use right eye example for any question.
I would give you a question, I might show you an eye that's already. Now you know whether it has an H on it or not, it's not that.
Erase the anatomy.
You got it?
I understand where we start.
It's a simple way.
That's why we're blue shirts. Like, just look at
They do.
yeah, you don't.
You got two more? Phase two is PA school, or phase two is. Right off the objective.
What's the exact opposite?
The 10 is a campus based. What's the size? Like,
That's it. That helps. That's literally it. Oh, well, go ahead. That's all I do.
Well,
So,
black box, I see you looking straight ahead. Come down and in.
I just wanted to do it.
But the guys that want to add us,
That was easy.
this is the black box.
Have you seen that they're exact opposites?
You're changing the side axis and you're changing the camera axis and the way the muscles line up. So often they like you're putting
That's
muscles
it.
on the slide
Now.
so that you can isolate. So what they found is if you add rectus first, inferior rectus can no longer do that. Like picture it's a slide. Now the only I just go to lift my arm. Realize that really these actions that's down there right now. When I look down there, it's not just one muscle. It's like a combination of 2 or 3 muscles. To get you to the training. So they said, well, if that's the case, how do we test it? How can we use this to test it? So they picture you stuck some probes in all 6 muscles. They said, okay, move his eye that way, now move it down. Like that. And we're like, oh my goodness, only muscle can fire. They do it more complicated than that. If you really want to learn, you want to pointers to it, and they show you how it's moving. And I used to show it. Not a lot of boxes. But at the end of the day, once you get out of the biology class here, you have to the only time
I don't think anything else has anything.
here, just gotta learn kind of both. Outside here, I'm being probably only things.
I usually just ask like curiosity. I say we boycott microphones.
Good. Yeah. A little bad, but it'll fix itself. You see where it broke.
It's like 30 to 45. The first was 30.
Did the radiologist say anything? Did he notice it was great? Nothing
Honestly,
over.
no matter how long it gets.
That's good. He said, I mean, it looks
You have
big,
two
it's
things
straight.
that you're right. There's so much data on that fucking.
Well, you're,
You don't know what you can tell.
there's a slight, there is a slight bend.
Like figure it out.
Because when you twist it, when you abduct it, it does twist over top. So it doesn't. 2 more weeks, and they said he'll get recasted to just a good guy. That little fiber that was sticking out, that's good. That's fine too. Remember the one piece that was asked either Rogero or Jimmy, is this going to have anything? And he said, yeah. Those osteoclasts are doing their job. It's crazy. Dude, it's like actually playing this stuff is like You see it, and you're like, wow, this actually makes a lot of sense.
It made sense the other day when I looked at it. Right now, like it's not making sense. I understand, like it's like a pulley.
And this is also why you can do this, but you can't do this. The rectus only pull.
Did I mention I was up 3 hours? Up 3 hours? I meant to tell you all those. All right, ready? All right, here we go. Here we go. We're at it again. I get even more crazy when I haven't slept much. I got to tell y'all that just I was whatever. I'm going to give dual credit for astrocyte foot processes. If you know what that means, great. If you don't, there was a question about the blood-brain barrier or capillaries surrounding, and if you go back and read that question, the way it was presented back to me from people was, I agree, it could be ambiguous a little bit. I don't completely agree with it, but because of that, I always say, well, I'm going to give you the dual credit on it. So if you answered astrocyte foot processes surrounding capillaries in reference to the blood-brain barrier, that's true. And it was worded a little funny in the actual distractor, but I'll say this. There are no astrocyte foot processes that come off of ependymal cells. And that's what it said, ependymal cell. Here's why I'm giving it dual credit. For those of you who are going, yeah, the answer was clear. I'm giving it because when it came to me as a rare example in my mind, the more I read it, as many times I've given that question, I'm going to change it. Because if there's one thing, if you look at every question across the board, there should be nothing that doesn't really exist. Meaning, I don't like fake answers. You don't make up stuff. And saying that astrocyte foot process is off of an ependymal cell, we made that up, right? You can use better distractors, and that's what I was thinking when I read it. You know, it's no different than saying, we had another example. Oh, like in test 3, I had a question that had MOA or comp as distractors. You remember that? And you're probably like, what the hell are those? Well, I'll tell you this, if you don't know what something is, you're like, I've never heard of that. Trust your brain. Your brains, whether you listen to me or not every day, normally recognize, yeah, I have no clue what he said about this, but I remember it being mentioned. That's different from you looking at comp and MOA and going, I don't know what that is. Well, don't answer it then. I don't know if anybody did. But we already brought them back up for looking at breaking down epinephrine and stuff, right? Now we know what they are. So my point is, on that test, you didn't really know what they were, but they're real answers. They are actual anatomy terms. When I read that question, I'm like, okay, you're making up something with the ependymal cell with an astrocyte foot process. I don't know if y'all understand what I'm saying. Either way, if you got it, you'll get those back. Once I finalize it. I'm trying to be fair about that. Well, we can't leave this yet. Let's do a couple of questions. Okay. I'm gonna leave this. We'll leave this up. You want me to just say it, or you want me to draw an eye on the whiteboard? We can raise screens and draw an eye on it. Do we have markers? I got markers in there? Yeah. Now, I'm going to do this, but this is not cranial nerves, where I'm going to ask you a heavy amount of questions on this one section. But more people get upset because they're like, I don't get it. I don't get it. Okay, well, don't get it. Don't get it. All right. Actually, I'm going to go over there and start on that side. We'll draw a couple eyes. I'm not an artist. I'm going to start over here, though. So we got to start with anatomy, because I'm more important. That's supposed to be a joke. pupil.
It's on another.
It's Casey.
Okay. That was not meant to look like anybody in here. All right. So here's the question. What is this person doing in eye-wise? They're looking straight ahead. There's no H over. It looks kind of crazy. You know who it is? It's the boss on The Simpsons. Mr. Burns. I didn't know I was an artist. Yeah, it's Bart. Okay, I didn't make his forehead big enough, that's all. I told you I'm not an artist. Okay. The eyes are supposed to be bigger. Okay, here we go. So we're over here with Mr. Wright. Mr. Wright says, okay, we want to know the muscles by movement versus gaze, but here we're just going to do anatomy. So if I say, okay, I asked this patient, or no, let's not say patient, sorry. So what muscle is responsible for moving? We'll do both. If this patient looks up and out, what muscle achieves that direction for that eye?
Inferior oblique. Inferior.
No.
It's inferior oblique, right?
When we're talking about the muscles, remember that the superior oblique and inferior oblique are reversed from what you think. So this is going to be inferior oblique that does that. Same thing. Let's go. So this eye, inferior oblique, which is what cranial nerve?
3.
1, 2, 3. All right. So in order to move the eye down and out, we'll be in what muscle?
Superior oblique.
Superior oblique, which is cranial nerve 4. All right. We'll put it over here. Superior oblique 4. All right. So now up and in is
Superior rectus.
superior rectus, which is, and then you have down and in, which is inferior rectus, which is also kind of 3. Okay. So I'm just going to draw this on one side, but what is, we'll put them both. This is lateral rectus, which is 6, and then medial rectus, which is 3. I did that so that I could go, okay, well, out of all of this, if we just looked at the nerves, superior oblique, lateral rectus, this red doesn't work well. Superior oblique, other side. And that's all that's going to change for us, right? And let's go ahead and put R6. So I couldn't get it to go in red, but if you look at it, we would look at eye movement. This is anatomy. And you'd say, okay, I could ask you a question. From the position of look, I could either show you an eye that's looking straight ahead. What if I said, okay, here's a patient's eye, whatever blocks it off, and they're looking straight ahead in the picture, and I said, what muscle moves the eye to the up and out quadrant if we're looking at the right eye? Inferior oblique, and you'd say, or you could say, what from the position of looking straight ahead, what cranial nerve is responsible for achieving the up and out direction of the right eye? 3. I didn't put it on the number over there. 3. That's Mr. Wright's boring anatomy. Y'all kind of getting that? That's what it looks like. And our only big differences are SO4 or superior oblique and lateral rectus are the only ones that aren't 3. All right. So maybe we'll get a better nose on this side. So that's anatomy, and you can just learn that, and I can ask you questions, and most of y'all can figure that out. Right. always think, are they looking straight ahead or not? Yes.
I'm trying to wrap my head around is where are the actual muscles located that are causing those actions? So the inferior oblique, is that located on that portion of the eye, or is it similar to the trochlear where it's like opposite direction of it?
It's kind of the opposite where it makes its attachment point. It's I'm trying not to have y'all get into that because there's not a whole lot of value in it other than we like to understand. Right? So, but once again, if you look at superior and inferior oblique, they attach it different ways on the eye so that, and if you were to come and label all of this, so that superior oblique, which is superior, right, it actually moves it down. Right? It does the opposite of what you would think because, like you said, that trochlea and it comes back. So its muscle is here, comes out to the trochlea, then back to the eye. So when it pulls, it's going to pull towards that trochlea and turn it down. And inferior rectus kind of does the same thing. To fully understand it, you really have to get into ophthalmology and start looking at the visual or the global axis of the eye and how it's really set up. It's not at all, this is going to sound funny, it's not all as simple as we're making it. I know this is not simple, but because we're not going to spend that much time talking about how the eye actually moves and its rotations and all this, the eye moves in rotational directions. We use a bunch of muscles to do that. So over here, all right, let me finish with one thing. So the eye in this, the right eye in the directions of eye movement, anatomy, and we say, okay, it's looking straight ahead. So what muscle achieved the up and out quadrant of the right eye? Inferior oblique. But we know that that's not really absolutely 100% true when you're walking around every day. Right? Because that's the mechanical axis way it's set up. But truthfully, when I walk around and I'm just moving my eyes wherever I want to, it takes 2 or 3 muscles to achieve getting the eye there. Right? So picture like anatomy. If he said, you know what, I need to do surgery on an eye muscle, which one does which? And they broke these down. And then they said, okay, well, what we found, though, is other muscles help to get to that. So in order to figure out which cranial nerve has a problem, if I want to take them into these different quadrants, I need to eliminate the possibility of any muscle helping to get there. That makes sense? That's what the eye exam is. So if you look at the eye exam, red's dead anyway. So if you come over here to the eye exam, we'll just do one way. We say, well, all right. So you have 2 eyes. Or if I was to show you this, and we said, okay, well, my right eye is, so you keep visualizing the lacrimal column. My right eye is what right now?
Abducted.
Abducted, yes. My left eye is
Adducted.
adducted. So we can talk about either eye. And so you're doing an eye exam on somebody, and we'll draw it. Now, if you're here or ophthalmology, if they show you a patient and their eyes are, or even if I do, and their eyes are already abducted or adducted in the actual picture of the eye, that makes the assumption that you are doing the physical exam. Because it's saying, that's another way of saying without like writing it down, when the eye is fully abducted or adducted, which muscle moves it here? That's a way of saying, showing you the picture, saying, well, that's a physical exam. But you could also, and generally they don't do this, and I don't always, you could say, well, let's do our H. That also represents an eye exam. So now that we're in the eye exam, we know we're going to do things. We're going to do this eye exam, and we're going to say, okay, well, let's fully abduct and adduct the eyes. So we do it. We don't just do one eye, right? If I'm this patient, I'm here, and they go out here. And now I'm adducted and adducted, right? Just like in the top. And then I'm going to go up. So what muscle, in that case, because we eliminated combined action, what muscle is going to move me up and out now?
Superior rectus.
Superior rectus, which is
And F3.
3. So my other eye is moving too. So this eye is fully adducted, and it's going to move up and in. And what muscle got me there?
Inferior oblique.
Inferior oblique, which is also cranial nerve 3. Right. So let's just go down to the bottom here and say, well, what muscle, if I'm fully abducted first, now we eliminated combined action where only one muscle can do that action. This is going to be
Inferior rectus.
inferior rectus, which is cranial nerve 3. And then if we come over to this side and say, well, it's down and in,
Superior oblique.
superior oblique, which is 4. Right. The reason I used those is because that's what's really changing is our, I should go back and do just one eye. Because if we were to, I don't want to say that. Y'all getting this? But it is just a swap, because if I drew one eye, and I said, okay, I don't know, we have to put both. I wouldn't do this like that. I may be developing a whole new paper cartoon section here. I'll forget that. I'm going to confuse it. Let me say this, and we're going to stop talking about it unless y'all got questions. During I moved my little rubber thing. Go. Back to this. These are my obliques. These are my rectus muscles. If you look at just the right eye, the rectus muscles are in between the eyes, right? My obliques are out here. That from the position looking straight ahead. Once I abduct or adduct the eye, particularly at just the bottom portion, they switch. Some of y'all are nodding going, okay, just leave it at that. And I agree with you. Here's the part I need you not to do. Quit worrying about how the eye moves. And just learn that that's a fact. I know that's a terrible thing to say as an instructor, but I also know how much you're going to be expected to know. Right? Unless you're an ophthalmology PA and studying this, and even actually by the time you get there and you say, hey, I'm going to be an ophthalmology PA, you probably won't even remember this lecture. And you just learn things. Because as a clinical PA, all that really matters, I'm devaluing my whole last hour, is Bates. If you understand Bates, you'll get it. But I will ask you a question or two on the difference. But I will always tell you or show you whether it's looking straight ahead or you're abducted or adducted first. I'll always let you know. You'll have a way to figure that out. Okay? If you really, one of those things, you really don't understand this, you don't think you got it, we need to sit and talk about it, because after a few minutes, normally I can show people, oh, you're just thinking of it differently here. But I don't know that until you tell me the way you're thinking about it. So if you're completely lost, give me and we'll figure it out. I should erase those boards. Well, let's get out of the tough stuff and say, what about something like strabismus? We're going to get some eye disorders. Strabismus will not go away. Strabismus is lazy eye. So they call it lazy eye because you have, I left the slide there. Strabismus means that if I'm at a Snellen chart at 20 feet away, or even anything you pick out, if I'm looking at, let's say the clock, I'm looking at the clock. Light rays are coming into my eye. My eyes need to be focused on the exact same spot. But if I have a lazy eye, that one is not focusing. We've seen that, right? We joke about it, whether it's not funny, but somebody has my sister had a lazy eye. I need to call her up today and apologize. She outgrew it by she didn't outgrow it, but she did exercises to get rid of it. But, you know, she'd be looking, and you're like, hey, you gotta look at me. Look at me. You can see why we haven't talked in years, right? No. I said that just to help you understand what it is. Yeah, her eye would track over. So they had her doing a bunch of pencil exercises and covering. A lot of times what they'll do is if your right eye is kind of lazy, they'll cover it. They'll cover your good eye and make you use that eye more. Because now you got to track things. So the problem is you're not looking at the exact same thing. Right? They're not focused on the exact object. And if that's going on, it's going to cause, you're actually going to develop, as we'll see in a second, amblyopia. You're going to develop vision loss, even though your eye is fine. So strabismus is a misalignment of the eyes. Lazy eye. Nystagmus is rapid involuntary movements of the eyeballs. There are many different reasons for this. It could be due to drugs, alcohol, could be neurological disease. Some people, you know, she runs in families. High-speed graphic there. So nystagmus is a sign, not a disease. Once again, I like to teach clinical stuff. That means that you can never diagnose somebody with nystagmus. It's a sign. The diagnosis is what's causing the nystagmus. Well, they're drunk. Okay, well that could be a diagnosis then. Inebriated. You got nystagmus. This is what police do. There are several different types of nystagmus. Most of the time you're looking at horizontal nystagmus. That's the most frequent. Horizontal meaning going back and forth across, like the police are doing the eye exam. Vestibular nystagmus and vertical nystagmus you see less. Vertical nystagmus we're not going to really discuss. We're going to discuss horizontal a little bit. And then we will bring back up vestibular nystagmus because that's associated with the inner ear and like the little calcium crystals in your ear that can get out of place. And we started talking about being dizzy and vertigo and whirling. Vestibular nystagmus, the best example would be getting on a merry-go-round. Spinning around a bunch of times. Then you come off. If you were to grab somebody right after they got off the merry-go-round and you grab them and looked at their eyes and held them still, you'd see their eyes going kind of crazy. There are other disease processes that can cause that too, but that's an example of it. So they use horizontal gaze, nystagmus, during the eye exam for whether you've been drinking. Because even if you've only had like 1 or 2 beers, even if you're not legally drunk, you can often pick up nystagmus in people's eyes. And so they get out there at the end. I was watching some type of cop show the other day. This guy was doing it. The police it was actually when he was doing the test, and the guy was passing all these tests on it. And I'm like, wow, he did the nystagmus, and police officers in here, he did the nystagmus test. I bet he did it for like 5-10 minutes on this guy. And he's like holding it out there. I'm like, you're drunk. You go drink some this weekend and do it. We'll do it on each other. You'll see it. A little bit of bouncing out there. Don't drink and drive.
I got a question.
Yeah.
Is it because of the vestibular nystagmus? You say how like the eyes be moving crazy. Is that also why you kind of feel unbalanced too, because of what the motion of your eyes, or is that got like inner ear stuff?
Yeah, absolutely, but it's not because of your eyes. Your eyes are the result of, picture your eyes trying to catch up with where your body, your brain, or basically your equilibrium receptors think you're moving. So if you stay on that merry-go-round long enough, it doesn't seem like you're initially, you don't been on a merry-go-round, I'm assuming. They don't have them anymore, it seems like, but the best thing I ever saw with merry-go-round is the one where they put in foreign countries that's also a well. That's awesome. I wish I had thought of that. But if you get on that merry-go-round, or if you get on the ride at the park where you stick against the wall, and it goes around and they drop the floor and you stay stuck to the wall, or you're in a plane, this goes into aviation medicine. Eventually you will catch up. But we got to study the inner ear for your question because there is fluid in the inner ear that moves and activates receptors. I'm going to be generic. And so if I get you moving and I keep you moving, the fluid will catch up and you won't feel dizzy. But if I stop you, especially if I stop you suddenly, that fluid's still moving. And as part of proprioception, your eye and vestibular inputs are connected, right? And so I always picture like your eyes are searching for right up. How do I upright myself? But it will eventually fade very quickly. But you can have vestibular nystagmus with other things like Meniere's disease, not Meniere's, forget that. You're not going to talk a whole lot about vestibular nystagmus, but it's involved with the receptors in the inner ear. So, but your eye is not causing you to feel dizzy. Your receptors are. That's what I was trying to say. Did I answer that okay?
Yep, yes, sir.
I'd rather talk about more disorders, but we're getting to the eye structures. It's easier than anatomy gaze. Okay, looking at the eyeball itself. We have different areas. You're going to have 3 different layers. You're going to have a fibrous tunic, a vascular tunic, and then the retina itself. As we're finally getting back to that. So if you look at just the fibrous tunic, that is the outside, the superficial coat of the eyeball. It is avascular. We see it labeled already on this picture. And so this is the vascular tunic. And it consists of the cornea and the sclera. The cornea is this transparent portion on the anterior side. And then the rest of the sclera is going to go from there all the way around the eye. We'll look at that on the next slide, but I couldn't get that straight. The cornea is important because it is a major refractive medium for vision. Your cornea is what determines a lot of your visual axis because it can reflect light. The sclera is just that white part we see on our eyes that helps give the eyeball kind of a shape. Because if you look at the sclera, the white of the eye, it has a bunch of connective tissue, collagen, fibroblasts, whatever. It's connective tissue, and it covers the entire eyeball except the cornea. So it's making it kind of rigid, giving it shape, and that's what we see on this thing here. And all of this is the white is all your sclera, and then you have your cornea. I can hear it rattling inside, and that's because unless one of y'all has been playing with it, I broke it last semester. There's supposed to be layers inside if somebody wants to put it back together, but then I'm going to pick it up and break it. So wait till I finish the eye lecture. I guess I should put that stand. So you have cornea and sclera. There's your fibrous tunic. And then you have a vascular tunic where guess what? There's vessels in it. Right? It's actually called the choroid. You have the choroid, you have the ciliary body, and the iris are all part of the vascular tunic. And so this layer that we see here is our choroid layer. But that's going to include the ciliary body up here that we'll discuss even more. And then the iris, which the iris is here. Right, because that's your pupil. That's how the light's going to get in your eye. So the choroid has all the vessels, and it lines the interior side of the sclera. So the sclera is going to get its blood supply from the choroid layer. Well, the retina is going to get its blood supply from the choroid layer also. It's situated between them. It's how these areas are going to get their nutrients. On the back side of the eyeball, that's kind of all we need to know about the choroid. But as it comes around to the front of the eye, it has what's called the ciliary body. The ciliary body consists of ciliary processes and ciliary muscle. So the ciliary processes are folds of that ciliary surface that contain blood vessels, capillaries, particularly, that secrete what's called aqueous humor, one of the fluids of the eye. And so all of this is so. Here's your iris. Here's the body, like that whole structure. And then it has folds in it. These are ciliary processes. And they secrete aqueous humor. Also part of that, those processes there, you have this large area that's called the ciliary muscle. And so from the processes to the lens, we'll discuss this more during refraction. There are these connections called zonular fibers or suspensory ligaments. So I don't know how clear I'm being, but this is the ciliary body, which where I put the arrow is really the ciliary muscle, and then it has some processes that come off of that, and connected from these processes to the lens of the eye are suspensory ligaments. Now you're never going to get it looking at 2D pictures until you come back to this thing and say, okay, you must recognize that here's my iris. Right? The iris, this portion that's up there above the lens there, that's like taking this and putting it up here, like this, right? The cornea is at the top. And so the iris, brown-eyed in this person, is there. So we're only seeing a cross-section of that. But you have to fully understand always that like the iris goes all the way around, right? It's a globe. And so we would have a ciliary body and muscle attached to the iris all the way around. And then you have a lens deep inside that those ciliary processes go to. Trying to give you all a visual, and looking at this helps to understand that it's a globe, it's not just a section. I'll keep mentioning that. I didn't really go into when you contract the ciliary muscle, it's going to actually reduce the tension on the suspensory ligaments and allow the lens to assume a more spherical shape. We'll talk about that under image. You have the ability to adjust the lens to focus in on things. And another thing, since it's part of it, is the iris. The iris is the colored portion of the eyeball, but the iris is all actually muscles that can contract. So the outer margins of the color of your eyes are attached to those ciliary processes. So it's all part of this layer. When you look at light coming into and out of the eye, the pupil, the iris, the iris is going to control the size of the pupil. It's going to do this using parasympathetic and sympathetic system. Now we know that in a sympathetic system, you activate the sympathetic system, your eyes are going to dilate. In that case, we're going to use the radial muscle. So the radial muscle is going to pull, if you notice the little blue areas, out like this, and that's going to cause your eye to dilate. If the parasympathetic is activated, your pupils constrict. And so in that case, the muscle that's going to do that is called the circular muscles, and they're here. So the radial muscles would relax, and the circular muscles would constrict. Remember, it's not an all or nothing thing. It's putting your foot on and off the gas for sympathetic, parasympathetic. So that's how they affect the actual size of the pupil. All right, and then the inside layer is the retina. During image processing, we'll talk a lot about the retina, but here's the retina. The retina lines the posterior 3/4 of the eyeball. So if we were to come up here and look at the front, this white area inside, this is the ora serrata, and the retina actually starts there and is attached, comes all the way down the back of the eye, skips that area, we'll get to that, and then it goes all the way back around. So it's covering the back 3/4 of the eyeball. It's the beginning of the visual pathway. Another way to say that is it's the first spot where photons of light are going to hit. We'll talk about tomorrow what that means. So it's interesting though, when you look through the eye, it's the only place in the body where you can directly observe blood vessels. Right? Not talking about just superficial veins, we're talking about blood vessels. And any pathological changes you have going on in the body, you can also see in the eyes, blood vessels. It's really interesting because I always laugh at physical exam. I don't go down there as much as I used to help y'all learn that, but it's always fun because if you're like me, I wasn't the high-speed person I am today medically when I was starting gigs. Just throwing that. Come on, y'all. I'm the tired one. Come on. Y'all know I got it all together. No. You're gonna look in this eye with an ophthalmoscope. Nowadays, everybody goes, yeah, I see that. And they look in there, and they got that big 3D scope, and you can just kind of look at it. No, you're going to look at it with an actual ophthalmoscope. You're going to get very, very close to people. Make sure you bring gum. Give somebody some gum. You're going to get up close and personal, especially if you do it wrong. Right? If you hold the ophthalmoscope with the wrong hand, you're going to be lip to lip. Don't do that. Right? I'm looking in the opposite. Anyway, you're going to take that and look in there, and for the first week or two, after you listen, after about 2 weeks, you're going to have somebody do this. Y'all have been looking in the eye, and they're quoting the optic disc ratio, the TM, or not TM, that's the ear or something. Anyway, you're going to be describing this eye, AV, nicking, da-da-da. But at some point, you'll hear somebody like a week or two, and after y'all been doing that and learning the script, what you're supposed to be looking for, and they're going to go. They're going to finally see the retina. First time. It takes, you got to do it a few times to get it. You're going to hear somebody go, holy crap. Have y'all seen what's in here? Have you never done that? Have y'all been doing that already this semester?
Yeah.
Okay, so y'all know what I mean already. So I'm speaking like the old days. I forgot y'all are doing that now. Anybody want to admit it? That you finally, after doing it a few times, you're like, you see that? Yeah, I see it. Yeah, like my kids. Yeah, I see it. You didn't really see it, and then when you do see it, you're like, wow, that's pretty cool. That's going to happen again for a lot of y'all during the whole main exam. You just make me laugh all the time. I, as the grader, didn't fault you. But I used to love when you have somebody, they're looking in the eye, and they're talking about the A/B ratios and cups to disc margins, and they're going through the whole script, and I'm checking them off. And the whole time they're doing that, I don't need this thing, please. The whole time that they're describing the inside of that eyeball, the light's right here. Not even on their pupil. And they're just going through the script. Half the battle in school is learning what you need to be looking for. And we've seen them in physical exam doing that. I have no doubt that they can do that. They get nervous in there. And they start looking in there, then they get on their script in their mind, and they're like, blah, 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 and I got to get the words out or he's not going to put a check on the paper. Me personally, I gave people a little credit. Not everybody does. They'll say something. Yeah. Nowadays, everybody has those big old things. They just look in the eye. That's no fun. All right, optic disc. The optic disc does not have retina overlying it. And when we look at the optic disc, it is a blind spot. I'll talk about that during image tomorrow, but the optic disc is where the optic nerve exits the eyeball. Where the optic nerve exits the eyeball, the retina doesn't cover that area, so it's a blind spot. And what goes through that area along with the optic nerves is central retinal artery and vein. Okay, they're next to that. But the back area of that eyeball, that's the optic disc. We'll discuss that more under image. So since we're talking about the retina, we have to look at the retina is actually pigmented. It has melanin and things in it. It's pigmented because when light is coming into the eye, if it wasn't, it would scatter all over the place. Okay? Light comes into the eye, and you don't want it bouncing around inside of the eyeball hitting the retina. You want to direct it to a certain spot on the retina, and so the melanin pigments in that eye, the retina, actually absorb stray light. Your vision would be kind of distorted without it. And the last part of the retina here is the important part. We say, well, there's the neural layer. Which is interesting is the retina neural layer is actually, they found out, same tissue development from an outgrowth of the brain. right? Because these are very specific layers. If you look at this compared to when we did it with cranial nerves, now we're going to come back and go, okay, well, we have this pigmented layer, and then we have a photoreceptor layer, which is our rods and cones. That's going to synapse with a bipolar layer of neurons. They're going to synapse with ganglion cells, which are neurons. So you have this outer synaptic layer and an inner synaptic layer. If you come over here to look at this side, you'd say, well, here's a cone, and a cone is going to synapse with that bipolar cell. Then that bipolar cell is going to synapse with a ganglion cell. And then the axons of all the ganglion cells are what leave the back of the eye as the optic nerve. It will make sense tomorrow. When we look at the neural layer, just looking at the rods and cones, rods or cones are what picks up the differences between darker shades, or like shades of like gray, black as we call it, nighttime. That's your rods. Low light threshold. You have a lot of rods. Cones have a higher light threshold, and you have color vision because of the actual cones. So these rods and cones are specialized cells that have photopigments associated with them and have the ability to absorb a photon of light, which is going to be the site of transduction. Like I said, some of this comes, right now we're doing the anatomy. We're going to get to the image and how this actually works. But photoreceptors transduce light into receptor potentials to send a signal to the cerebral cortex of what you're seeing, so you can perceive that. Right? The light is going to be the stimulus. Okay. Another area at the back of the retina is it just me because I've been up so long? It's like, I feel like it's gone up 10 degrees since the break. Not me? All right. Here's that. I'm all of a sudden nervous again. The macula luda, an important area because it is the most visual acuity spot on the retina. It is the center of your visual axis. In the middle of it, there's an area called the central fovea, or fovea centralis. Okay, so this is the macula luda. And hopefully, as you'll see later, it's without lesions. There's the macula luda. As light comes into the eye, goes through the cornea, through the lens, we want the light to strike exactly at the central fovea of the macula luda. We want it to hit right there. If it doesn't, we're in glasses. Don't dive into that just yet, right? Or you can get PRK like I had, stuff like that. We'll talk about it. So the central fovea, though, for anatomy-wise, only contains cones. Cones provide color vision and our most acute visual acuity, so we can see things very clear. Another unique thing to the central fovea is it does not contain rods or cones it does not contain bipolar or ganglion cells right in front of it. Okay, they're not there because they're blocking. They're to the side, so you don't see them in that area when you look microscopically. They would distort vision a little bit, and this is our highest visual acuity. Just get the parts for now. We'll come back. Blind spot. The optic disc, I said, contains no rods or cones either. The optic disc, not either. The other one, sorry, the central fovea just doesn't have ganglion and bipolar cells over it. But the optic disc doesn't have rods or cones. So that's where the ganglion axons are leaving the eyeball as the optic nerve. That's called your blind spot. You can actually find your blind spot if you take and make a pencil head, number 2 pencil eraser size dot on a piece of paper. You can take and cover one eye, and you slowly move that. You look straight ahead, but move the paper, and you can see it out of your peripheral vision. Eventually, if you do it right, you'll see that dot disappears. When it disappears, you've found your blind spot. Oh, sorry. That's it for today. But once and only once, I printed up a bunch of those and brought them into class for people to give it a try. It went over like I just told them, hey, we're taking the next 2 micros this afternoon. And they were such a fuddy-duddy class. That's I didn't have fun with that class at all. That's why you have to draw your own dot. Y'all have a good day.